phenotypes and what are the management strategies that we can use for cough? This is an extremely important slide, okay, for clinical practice. So chronic cough phenotype, you can have one is a cough variant asthma, where, or you can have eosinophilic bronchitis. What happens here? There's inflammation, there's nocturnal presentation of common with concomitant asthma. It happens, the symptoms are more the cough is more at night, and the area of the wheezing or breathlessness may not be there. So when we say about a cough variant asthma, we are talking about a cough which is can be the only symptom, and these individuals are may benefit with inhaled corticosteroids. So cough variant asthma. There's a workup which is done for these individuals. We may do a spirometry, we may do a bronchial challenge test, and before we come to the diagnosis of cough and asthma, and we'll discuss as we go ahead. Often it's a clinical diagnosis, and then sometimes it may be supported also by the lung function test or the advanced lung function. Now, reflux cough is very common in clinical practice. The diagnosis depends on symptoms. It can be heartburn, chest pain, a sour taste in the mouth, and regurgitation. These are very strong symptoms suggestive of acid reflux cough. On examination at the back of the throat, you may find something called as a granular pharyngitis. So if you find a granular pharyngitis, that can be one of the reasons to suspect gastroesophageal reflux. Now, postnasal drip in people who have rhinitis, rhinosinusitis, the nose can flow forwards, can flow backwards also. In the past, it was labeled as a postnasal drip, where the secretions went to the back of the throat. They affected the irritated the throat. They hit the voice box, and they created a cough. Now, that's called as a upper airway cough syndrome. Okay, and it's the sensation of the nasal secretions which lead to the cough or clearing of the throat. Okay, so very important reason for cough. And iatrogenic cough, I mentioned, we can buy the ACE inhibitors and bisphosphonates. Bisphosphonates are typically used to treat osteoporosis, and several of our chronic patients, who may be on steroids, who are elderly, who are not very mobile, may be at risk of osteoporosis, and often they may be on bisphosphonates. So we have to find out, if the addition of the bisphosphonate was responsible for increase in cough. So what's the approach to a case of an acute cough now? It's very important. Either it's a medical emergency, depends on the onset of cough, the duration, and what are the associated symptoms, allow for that. So if it's a medical emergency, then of course you look for heart failure, COPD exacerbation, a foreign body explanation, you would treat that. So that's out. What is important for clinical practice in OPD-based practice? Outpatient-based practice. You can have respiratory tract infections, so there can be an upper respiratory tract infection, could be viral infections, a lower respiratory tract infection, or a lower tracheobronchitis, asthma, COPD, bronchiectasis. All these things, once they flare up, can manifest with cough. And typically, if you have someone with asthma or COPD who presents to us in practice, the common symptom along is cough, and that may be often associated with breathlessness also. So that is the acute cough. Now, subacute cough. Subacute cough is for 3 to 8 weeks. Whenever somebody has a cough for 3 to 8 weeks, you have to think about post-viral. Post-viral is very common, and sometimes you can have a post-viral cough lasting for a few weeks. It could be interstitial lung disease, pneumonitis. It can be an occupational cough where individual is going to at the occupation, is exposed to some triggers, has a cough during that part of the week, and when suppose the individual has a weekend off and is at home, is not exposed, the cough goes down. So this history is very classical to identify occupational cough and asthma, and also GERD, gastroesophageal reflux disease. So typically for individuals, sometimes they may not have all the symptoms for acid reflux, such as a burning sensation of food coming out of the throat. It could be in a small amount, and it can still lead to cough. So that is something that one has to keep in mind. Now, what are the most common reasons for chronic dry cough? I think it's again, we've put this up here. It's very important. Gastroesophageal reflux, whereas airway reflux, amounts to almost 40%. Okay, so reflux is something that we have to look for. Upper airway cough syndrome is something which is also very important. often missed and not treated adequately. I would say maybe the diagnosis is made but not treated adequately with the duration of therapy, the duration of therapy. And then, of course, you can have asthma and non-asthmatic eosinophilic bronchitis. So, as I said, the upper airway cough syndrome has replaced the term postnasal drip, and cough in this case is mainly attributed to rhinitis and rhinosinusitis. Chronic dry cough presents as a predominant symptoms or the only symptom in asthma. Some patients with asthma will present only with cough. Now, when it comes to evaluating dry cough, different asthma. So, what would be an asthmatic cough present with? They get an early morning cough. There is a family history of asthma or eczema or allergic rhinitis, and the triggers for this cough are exercise, change of weather, laughing, crying, and they've got times when they're absolutely symptom free. And the thing is, they often respond to a bronchodilator. So, in such scenario, you have to consider asthma. You need to do the workup for these individuals. For me, any patient who comes to my clinic, we will do a spirometry, which is a very simple test to be performed, and that will clinch the diagnosis in a large number of patients. If spirometry and everything else is normal, you still suspect that there may be the cough may be attributed to asthma. Based on the clinical evaluation, you can still give a trial of inhaled corticosteroids for a few weeks and then see. If the patient responds, now this is very important, then you can continue for 3 weeks, stop the steroid, and if the symptoms recur, you start the inhaled corticosteroids again. And if the patient improves, that would also endorse the diagnosis of asthma. So this is a clinical diagnosis of asthma, or what we call as a physician diagnosed asthma. Now we talk about post-viral cough or post-infectious cough. This is a cough which is persistent after a viral infection. It persists for more than 3 weeks. And, typically the X-ray and the spirometry are normal, typically self-limiting. People, if you suspect there's a secondary bacterial infection after the viral infection, a few days of antibiotics can be given. And some may require antitussives, antihistamines, and decompression. So I think this is an area where the symptomatic treatment is extremely useful. And this is the area where, cough suppressant, maybe syrups or lozenges can be very, very useful in reducing the cough. So how do you, suspect a post-infectious cough? Cough which is there for more than 8 weeks following an acute infection. There's an uncontrollable urge to cough, and various physical or psychosocial effects are associated with that. So if there is a wheezing, often we see that the post-infectious cough can also come with tracheobronchitis, and these individuals can have wheezing. Okay, this can be just as a post-viral bronchitis. They are fatigued, they've got sleep disturbance, they've got retching, vomiting, urinary incontinence. And when you say urinary incontinence or cough syncope, that means it's really a severe bout of cough which can cause the cough syncope or a urinary incontinence. How do you manage this? We have to identify and treat the peripheral triggers. Appropriate antitussive medication is extremely important in such patients here, including local anesthetics, opioids, neuromodulatory agents, and also antitussives are used for treatment of a refractory cough. So now that we've discussed about acute cough, subacute cough, chronic cough, what are the etiologies and what is the treatment approach. We've discussed about asthma, we've discussed about cough variant asthma, we discussed about upper airway cough syndrome, we discussed about gastroesophageal reflux. We've covered a significant, the common reasons for the cough. What do the guidelines say? Now, this is an extremely important paper. I think this is the indicator statement where the Indian experts got together to prepare a consensus statement for management of cough at a primary care setting. Okay, so I think this is a very important and a very interesting document, which was the method they used was the modified Delphi method, was used to arrive at a consensus, which makes it quite a strong method of making a consensus guideline. Now, when we talk about, when we are talking about cough, just a minute, please. Yeah. So now in this scenario, when we talk about cough, how do you assess the cough, particularly if it's an acute cough? So what we are going to do is we are going to differentiate this between we are going to differentiate this between acute cough, subacute cough, and chronic cough. So that's what these guidelines have done. That's the way they have gone ahead. So when it comes to an acute cough, again, you have to see what is the intensity of the cough, the frequency of the cough. You do the medical and the drug history you have to take. You have to see associated symptoms with is there, and an examination has to be done. If there's a red flag sign, such as a pneumonia, COPD, asthma exacerbation, pulmonary embolism, it goes on to a different level. You treat the primary reason. But if it is not an emergency, then you see, okay, is this cough productive or is this dry? If this is a dry cough, then you would give them non-opioid antitussives, antihistaminic, decongestants if necessary. And typically, if you have URTI, your treatment is symptomatic, you avoid antibiotics. Unless, so when do I give antibiotics? Particularly if I guess there is a discolored sputum, there's some fever which is lasting for more than a couple of days, that's when I would give antibiotics. So if I have a suspicion of a viral, I would typically avoid antibiotics. So treatment dominantly is symptomatic here. If there is an COPD exacerbation or asthma exacerbation, we would treat that with steroids or antibiotics. And of course, if there's a pneumonia or something, we would clearly treat that with a antibiotic. So that's about acute cough. Now we move to subacute cough, that is between 3 to 8 weeks. What are the, how do you approach this? So for anybody who has a cough for more than 3 weeks, it's extremely important to evaluate it systematically. Typically, they will need an X-ray test, a pulmonary function test, and a CBC. A CBC is very important to look for infections, eosinophilias. An X-ray will help you to see if there's any infiltrate, and a PFT will help you to find out if there is excuse me, if there's asthma or an underlying obstructive airway disease. So in this case, if it's post-infectious, you manage it symptomatically. I said, symptoms management is extremely important. If it's an upper airway cough syndrome, there's a post-nasal drip, then you will use either antihistaminic, or you will use a or you will use a nasal spray. If you have an asthma or COPD, you will avoid the triggers and use the GINA or the GOLD guideline. That's clear. If it is tuberculosis or any infection, you treat it with appropriately. And if it's an environmental exposure, you reduce the environmental exposure. And of course, in this, the most important thing is, for anybody who has a cough for more than 3 weeks, you need to rule out infections in areas where the infections like TB, etc., are common. And you also need to look for asthma. Now we come to the chronic cough. So somebody who has a cough for more than 8 weeks, how do you go ahead? You do a physical examination thoroughly, you do X-ray, spirometry has to be done, a CBC has to be done, an additional test would be done. And then in the clinical examination, you would look for, crackles, etc., because where is there an interstitial lung disease? You need to rule out, you need to assess for asthma, COPD, and also for interstitial lung disease. Now, it could be an upper airway cough syndrome. Now you'll say, Doc, why more than 8 weeks, we think about upper airway cough syndrome? Because if there's a rhinosinusitis, typically patients, as I said, in practice, will receive treatment only for a few days. They get symptomatic benefit, and then it comes back. So if it's upper airway cough syndrome, they may need a steroid for a slightly prolonged period. GERD is also very important, often missed as a cause of cough, and therefore it's extremely important. So if you identify GERD, you have to treat it appropriately. And as I said, that if there's asthma, COPD, you follow the guidelines. And if there is an eosinophilic bronchitis, you would treat that with an inhaled corticosteroid or plus minus with a leukotriene receptor antagonist such as montelukast. So I think what we've done is we've given you an overview about what the guidelines say about management of acute cough, subacute cough, and chronic cough. How do you clinically suspect it? How do you do the workup? And how do you manage it? So it is actually quite systematic. The approach has to be very, very systematic. So now when we come to about the treatment now, when we talk about if you have an unexplained chronic cough, codeine is to be prescribed only under supervision. So typically we use, say for an interstitial lung disease or a chronic unexplained cough, we may use codeine. We explain to the patients, we tell them the side effects, constipation, drowsiness, etc. For the risk of addictiveness, and then it has to be done under supervision. Do I use it for acute cough, acute or subacute cough? Subacute cough, maybe rarely when the bouts are too severe, patient is having too much of a problem, then I can use it for a very small duration of time. But the guidelines recommend to reserve it for cough more than 8 weeks. Now, another important thing is speech and voice therapy, for cough suppression. So there are several breathing exercises that can be done to help with the cough suppression. And so that is unexplained chronic cough. Now, what about chronic refractory cough? That means, you've done everything. What is chronic refractory cough? You've done everything to diagnose. You've not got any proper reason for the cough. You've done all the tests. You've given all the medication that we've discussed step by step, and still the patient has a persistent cough. What do we do for this? For this, we may use, of course, morphine or codeine substitute medications, but also gabapentin or amitriptyline can also be used, because there is this thing called as a neurogenic cough. Often we might need to take the help of our neurologist colleagues in such a manner, and then these can be considered, gabapentin or amitriptyline can be considered once a diagnosis of a neurogenic cough has been made. Speech therapist is extremely important, speech therapy, voice therapy. So we involved our speech therapist, and then they can help with the breathing exercises and the speech therapy, etc. And that can also contribute to the symptoms control. So now I've discussed with you about the Indian guidelines, the acute cough, the subacute cough, and the chronic cough, the refractory cough. What is the approach, and how do we go ahead in treating it? Now, what are the other international guidelines? I will just go through some other international guidelines also. So there is the ACCP the CHEST has come with an algorithmic approach towards management of cough based on the cough phenotype. And what they say is that managing cough as a symptom in children and management, they've done these guidelines. They've done managing chronic cough due to asthma and non-asthmatic eosinophilic bronchitis in adults and adolescents. This was done in July 20. So these are the topics that have been covered. Excuse me. So the person who has led this is Richard Irvin. We know he's been the former editor of CHEST, editor-in-chief of CHEST, and his area of interest has been cough. So now this is a very good figure, okay, for understanding chronic cough. This figure talks about treatable traits of chronic cough, and what are those? First, let's start here. You look at medication, ACE, ACE inhibitors. So you need to identify that. Smoking is something which is there. Smoker's cough, we know is there, and it's somebody with COPD. You're treating the COPD with the guideline. Smoking cessation has to be undertaken. Obesity. Now, obesity is also cough. If you have a crowded upper airway, they have reflux, they've got a continuous irritation of the upper airway, and if that is combined with sleep apnea, we know that sleep apnea, because of the irritation of the upper airway, they've got a very crowded upper airway, can be a cause of cough. And there are papers to show that obstructive sleep apnea worsens the gastroesophageal reflux symptoms, particularly at night, and hence you need to identify sleep apnea and treat sleep apnea, and particularly if your patients are complaining of nocturnal cough. From the lung point of view, you need to look at the underlying disease, whether there is asthma, there is COPD, there is bronchiectasis, there is interstitial lung disease. You need to identify that. Anxiety, as I said, can be a reason. You need to identify. In one of the case presentations, I said I highlighted that you need to look for depression and anxiety as a cause of cough also. Then you look for chronic rhinosinusitis. You've got cough hypersensitivity, got acid reflux. So I think this is a very important figure, and that's something that we can really follow for a step-by-step evaluation of chronic cough. Because when an individual who comes to us with a cough for more than 2 months, I think we need to give some time and take that individual systematically. So what do these guidelines talk? They talk about an empiric integrative approach to management of cough, and they say an effective approach to successfully manage chronic cough is evaluate and treat common causes of cough with using a combination of selected diagnostic tests. So yes, we need to do tests, and we said this, yes, if it's a subacute cough, you need to do more tests. And empiric therapy, you have to treat them symptomatically. For every cough, you can't land up doing a test. So, if it's a post-viral thing, if it's a acute cough, which is going to, resolve a period of time, and you need to give that individual a symptomatic relief, you need to treat that symptomatically. Important sentence now. Sequential and additive therapy is often crucial. Sequential and additive. So you sequentially add therapies because there can be more than one cause of cough, which is contributing chronic cough. So often what can happen is somebody's got a chronic cough, you've treated only one component, but the second component has not been treated, and therefore the symptoms can persist.